So very good afternoon, friends. I welcome Dr. Ashok Khurana and all the viewers for this FOXIS initiative webinars. As you know, since last 2 months, we have started to organize webinars in this time of social distancing and lockdown. Our academics is going well, and we are regularly updating our knowledge by regularly organizing webinars on different topics. This is the number 20th webinar since last 2 months and 10 days. And I would also like to inform Dr. Ashok and all the viewers that on 10th May we had a wonderful celebration of Mother's Day. From morning to evening we have celebrations. We celebrated the day for the cause, strengthening India by Beti Bachao, Beti Badhao, Beti Padhao and Beta Samjhao. And in the morning we had virtual walkathon. We wanted to register to make a record, FOXIS record in India Book of World Record. And we need 10 lakhs steps, 1 million steps. And I am happy to inform you, we have reached nearly 49 lakhs, nearly 5 millions. We achieved 5 times more than what we expected and we have planned. Another thing, in the afternoon, we had wonderful scientific program, e-conclave on women's safety and empowerment. Various dignitaries, well-known personalities were invited: Kiran Bedi, Sarman Joshi, Diya Mirza, Geeta Jain, member of MLA, and Dr. Deepa Malik, a paraplegic athletic tournament world champion. So many personalities from so many different fields were invited. They all spoke very well from their heart. They gave very good message. I am happy to inform all of you that the viewers were unexpectedly very good number. We have reached to 42,000 viewers. So it is the ever highest number of viewers in any FOXIS program. So 42,000 viewers across India have attended our e-conclave program. And we also had a slogan competition and musical programs, 1 hour continuous songs on mothers. So we celebrated very well with the support of all of you. And so I want to take this opportunity to convey thank you from my bottom of my heart to all of you for participating wholeheartedly in all the FOXIS events and FOXIS call and FOXIS cause. And thank you very much for taking FOXIS vision, efforts and work to all the people of India. Today we are going to discuss in this webinar, I think, basics of color Doppler in obstetrics. And we have eminent personality, eminent faculty, my friend, humble person, Dr. Ashok Khurana with us. I always learn to learn from him. It is always a pleasure to listening him. I attended so many lectures of Dr. Ashok Khurana, and I am sure definitely today you will have many good messages, take-home messages. So with this, I request Dr. Ashok, please start your talk.
Thank you, Dr. Alpesh. It's indeed a pleasure to be part of this mission. Not that I've ever been out of step with FOXI, part of FOXI for so many years now. I've been a FOXI member for 39 years. So, and it is indeed great to partner with FOXI and to be invited by FOXI for the Society of Fetal Medicine to give some of these webinars together. The idea really is to put everybody on the same page, and I think we would like to truly enjoy that, and therefore it's fantastic that we are able to get together to do this. And what I will do is to take you through what we just discussed, which is the actual basics of Doppler, not from a mathematical point of view, certainly not, but truly what we call partnering, which means that you and me and everybody who works for the good outcome of the fetus is going to be in a situation to speak the same language. Because currently what is happening is that we have all this Doppler. And the radiologist says something, the sonologist says something else, the fetal medicine specialist with a background in obstetrics says something else, and the clinician is left exactly where he or she was at the beginning of our whole exercise. The aim of today's exercise is to use applied mathematics only where relevant, to discuss and clarify that Doppler is safe, and then to discuss fetus pathophysiology, which means what is different in the fetus that is challenged during its pregnancy, and how does Doppler help us to identify that, follow that up, and in situations take important delivery decisions. I will also discuss briefly how we get further information on fetal structure by being able to identify fetal anatomy better when we use color Doppler, and also a differential diagnosis on the basis of color Doppler and the prognosis of anomalies based on color Doppler, because that indeed is the crux. Anomalies are not something we like to destroy all the time. We want to give every fetus a best possible outcome. We like to give our patients options, and therefore we seriously feel that yes, Doppler helps in these situations, and we'll take up some examples there. Of course, there are also as markers for anomalies, and particularly in the first trimester, and we will discuss that as well. What I will not waste your time with is what does not help us to be on the same page, and that is how do we go about doing Doppler? Certainly not only how is Doppler done, and therefore what do I need to understand Doppler, and how do I use it to make my clinical decisions? And it's not going to be an atlas or a showcase, no. It's going to be, today I have this situation, today I have to sort out this situation, I have several clinical options before me, and which would be the wisest option for this particular patient, and so on to what I'm going to be discussing today. So the idea really is to make sure that we don't talk different languages as you see in this illustration. The idea is to put ourselves on the same page, that we are in agreement on what is necessary as information required for a clinical decision, and that we have a harmonious working relationship where what I put in my report is understood correctly by the treating clinician, and the patient benefits as the final requirement of clinical care. So with that in mind, we will go ahead and of course discuss where Doppler is maximally used, and that is in fetal hypoxia acidosis in the second half of pregnancy. There are of course multiple other uses, and I will go in order of importance. So we will discuss first trimester genetic and anatomic diagnosis and uterine artery studies. We will discuss how fetal anomalies can be better delineated, and if we get time we might go through the rest of it, but I'm going to go pace by pace and see, and I've given importance to the ones that we see more frequently, and how we need to understand the basic information that is required, the basic information that is given in a report, and how it may be hidden in some corner of the report and where to find it. And if it is not there, then why not just have an opinion where that information is there? So is my report adequate? Is the report I have in front of me adequate? Will also be a result of this whole thing. And like I said, not just simple straightforward things like, okay, this is umbilical artery and this is the normal flow velocity waveform as you see on the top left, and then the waveform disappears at the end of the cycle, and then you have reverse flow, and therefore you have to do a decision making. No. Yes, we will discuss color Doppler, how we map out the blood vessels, and then the waveforms, and then how to analyze these waveforms. But more than that, a greater situation. Can I see my heart anomalies better, such as here? First trimester, 13-week fetus, I see beautifully the outflows and my two left and right ventricle of the heart with a simple flick of the switch which says Doppler. If I have to look at a single umbilical artery and I'm not sure in my 11 to 14 week scan, I switch on color and I get a much more confident diagnosis. And that again is part of Doppler, more confident diagnosis. If I were to see a fetus like this in 2D and find a mass in the neck, I won't go and do it 3D. That's not going to give me additional information. I know there's a mass in the neck. What I want to see is it the thyroid gland? Is it vascular? Is it anything else? Is it bizarre? And then, therefore, how do I investigate the maternal background? And does this fetus need intervention? We will also take you back and forth a bit and see here, for instance, is new technology. 2D in the background, which is seen as 3D, and also flow. So the heart here is seen because of Doppler being seen, and it's lying almost outside the thorax in this fetus, which is about 8 to 9 weeks. The umbilical cord is here. Below the umbilical cord, there is hardly any wall, so I start suspecting bladder exstrophy already. And above the umbilical cord, I also see a defect, and that I know because it is not with the cord at its apex that this will end up being ultimately a gastroschisis and not truly an omphalocele. So all this information, further information is possible with Doppler, and we'll discuss the more common scenarios, then move on to some of the rarer scenarios depending on time permitting. We have a lot of guidelines to guide us, and these come from our COG, they come from the Canadian societies, the Australian societies, but the ones I like to use the most in terms of how to do it is the ones from the International Society for Ultrasound in Obstetrics and Gynecology, which we fondly call ISWOG. And they have these guidelines now for about 6-7 years. It's a free document on the internet. All of you who wish to see it can download it and study it. And it will teach you how to do Doppler and how to go about it. But I will go beyond this document. And what I want to do really is that, yes, that you can study whenever you want to. But what I will take you through is to realize that guidelines does not mean this is to be done all the time. Yes, these are practice guidelines with minimum standards, but you can go beyond the minimum standards where necessary because, like I said, color Doppler is a problem-solving modality. Then, there are some situations where you have enough, no budgetary constraints, no equipment constraints, and enough expertise, and then you're fine. You can do whatever protocol advanced as you want. But there are a lot of institutions in our part of the world where we have patient load which is excessive, we have professional expertise which may not be equal, some may be junior, some may be senior, some may be junior but more experienced, and some may not be, and other economic considerations on giving this as a population-based testing. We don't have that yet. We need to, because as I will discuss in the preeclampsia section, we need this. But what each institution needs to do is to say that, look, when I do my ultrasound scan, we have problems with patient load, economic restraints and expertise, and therefore we will not routinely include Doppler, and we will only do it when specifically asked for in a specific clinical situation. So those are called institutional protocols, and each one of us is free to do so, because not everyone has to look after the same degree of sick patients, and we have to somewhere stratify. And therefore, that is perfectly justified. And this is what is mentioned in all the guidelines, that you have minimum practice, you have institution protocols, which is limited practice, and then you have keeping up to date. Whenever guidelines come, and it takes almost 2 or 3 years to get guidelines across, and this is with any institution in the world. What you and me need to do is to realize that science moves on much faster than that. So as of today, for instance, the emerging scientific evidence indicates to me that in the 3rd trimester growth scan, I should no longer do just a biometry, but also a multi-vessel Doppler. And therefore, in my protocol, I would incorporate that. And in terms of the economics, that depends on the institution that I work in. But ideally speaking, for decision making today, a growth scan will include Doppler, and we will discuss this in detail. So that is the background that we must have in the basic understanding of Doppler. It's not anomaly scan with color Doppler. No. The anomaly scan, the only scan that is required in color Doppler is the uterine artery flow, because you want to assess that. But this is where we stand best, that yes, we will do it, and if we don't have the expertise, we will not do the uterine artery, and that is something we have to work on. Now, the next issue I want to clear right in the beginning is safety issues. That means, as I go along, I must know that ultrasound is safe, that transvaginal scanning is safe, and we do a lot of our color Doppler with transvaginal scans. That spectral Doppler, which is not just the color mapping, but the formation of the waves, is also completely safe after 10 weeks. And before 10 weeks, it is not to be used on the fetus, but can be used on the fetal environment. For instance, in the adnexa to see whether there is ovarian torsion or to see uterine artery flow if necessary in cases which have had recurrent pregnancy loss. Transvaginal Doppler is safe. 3D Doppler is also safe, but we always use the ALARA principle, which means that as far as possible, you use Doppler to get images with a Doppler exposure as low as reasonably achievable to get the information you want to give. So it's not that you keep on doing it and doing it to get an ideal picture. You get it to work towards a working picture, and that is one of the basic principles. And one place where we should not be using it for is to record heartbeat before 10 weeks of pregnancy. The correct way to record a heartbeat before 10 weeks of pregnancy should be safe for the fetus. When we do spectral Doppler and you hear the boom, 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 boom of the Doppler, that is focusing energy on the endocardium, which is prone to injury, and we don't know the long-term effects. So until 10 weeks, we should use M mode and not spectral Doppler to demonstrate cardiac activity. Moving on, what is this color business all about? There are two parts to it. One of them is that you have color on anatomy, like here, a heart seen from this side. It's a view that shows me the heart and the aortic arch and the vessels that come out from the aorta, and this is called color flow mapping. I can then place a Doppler gate, which is a window that will tell me the type of flow, and when I switch on that window, it tells me the waveform, and this is called a flow velocity waveform. It has a peak, which is systole, it has a trough, which is diastole, and it has a time to the peak and a time to reach the trough, and we always look at the amount of flow between the baseline and this trough. Very often you will find that this direction of flow is something we have to understand. Red is usually flow towards the transducer and blue is away from the transducer. So this is not reversed flow. This is just that when I was insonating the umbilical cord here, red was actually the veins coming in my direction, and therefore it shows up as that, and blue was the other one, and therefore my waveform will be on the opposite side. When I talk about reversal of flow, my diastolic component of the flow comes below the baseline, and that is something we must understand. So basically we have direction of flow, which comes in color Doppler, and we have color flow maps, and we have spectral Doppler. So the waves are called spectral Doppler, and there's nothing complicated about that. We've learned how to use that information. Also that we have gone beyond color Doppler in recent years, and we now, instead of depending on flow direction and the range of velocities and the mean velocity, try and detect energy, which displays intensity, which is called power Doppler, which traditionally is this yellow stuff. This has sensitivity to slow flow. So particularly in the pelvis and in very slow flow vessels in the fetus, we use power Doppler. Previously, power Doppler did not have direction information. Now it does, and that is known as directional power Doppler. And we also have something called slow flow. Each detects lower and lower and lower flows, so you get a much better idea of perfusion in terms of total perfusion, and you get a much better idea of anatomy because the smaller vessels also light up. And let me show you what this slow flow means. Look at these transvaginal scans, and you can see that here I'm seeing excellently my entire pericallosal artery draping around the corpus callosum, and here I see the basilar system showing up beautifully at the back, and this is slow flow. This was power Doppler, and here I see even more vessels, and I can see the branches going all the way into the cerebral cortex. Here again, an example of changing the setting, changing the map, and getting the same information, the circle of Willis. So all of this is possible not only by transvaginal scans, but by transabdominal scans like this one was, because it detects very, very, very slow flow. And this is the kind of progress that mankind has made. We find high flow, like in the umbilical artery or the middle cerebral artery or the heart, and we find very slow flow, which is in the smaller vessels and is very cleanly picked up. Examples here of perfusion through the kidneys, and here you can even see the entire venous system. You can even see the vena cava going in there, the ductus venosus coming to it, and the aorta coming all the way down. So this is the kind of detail we can get, and we're combining here 2D information with the flow information, and so you're getting an excellent idea of perfusion plus anatomy and knowing that it is absolutely correct. And we will discuss where it is used. Here, for instance, is blood flow through the orbit, and this again is an example of slow flow transabdominal at 20 weeks of gestation. Great information which we will put to greater and greater use every day. And here is something very interesting. Here, for instance, is the lens within the orbit, and do you see this? The hyaloid artery is persistent, and we know that occasionally this can be a marker. It used to be regarded as a marker before, not a strong marker anymore because it required equipment. But now that we have the equipment, we will again start using it as a marker for trisomy 21 in the future, because now we have that technology. So that basically you must understand that there is color Doppler, power Doppler, directional power Doppler, and slow flow. It can be used not only for blood vessels, but for any organ where you want to see flow, like inside the heart, and you can combine it with 3D. So we also have 3D color Doppler and 3D power Doppler. And here you can see how nicely we're looking at this wonderful business of the vessels crossing each other and how well all of this is showing up. Now, here we want to see in this particular anomaly whether we have a situation where a mass in the thorax, largely solid, echogenic with a few cystic spaces, is a sequestration, or is it a mass that is actually a congenital pulmonary adenomatoid malformation? So I get my vessels going and I say, wow, the vessel is a pulmonary arterial branch. Therefore, this is a CPAM and not a sequestration. And while I'm doing that, I realize that yes, the drainage is nowhere aberrant. It is going exactly where we expect the pulmonary veins to be, and so we're happy with that as well. A sequestration, on the other hand, which is again an echogenic mass in the thorax, lights up when I see it with color in this way, and I combine it with 3D over here, 3D flow, and I see that the vessel coming to it is arising from the aorta. And when the vessel coming to it is arising from the aorta, then I know it's a sequestration and has an even better prognosis, because almost all of these will anyway go away. And whether a sequestration is within the thorax or outside the thorax, the supply of a mass from the aorta would mean that yes, it's a sequestration. You could of course have hybrid lesions which have a supply from both, but then again the prognosis of those is different. So it's a great way of using it. When we use the higher flows, we don't only look at the pattern, but we also have been traditionally looking at indices. And the first indices that came out was the ST ratio. Indices are a way of quantifying the spectral Doppler. When we divide the peak systolic velocity by the diastolic velocity, we used to get the ST ratio. It was used for a long time. But then we realized that as these hit zero, the end of cycle flow, the diastolic flow hits zero, we don't get a figure. And so we moved on to the pulsatility index, where you have the systolic minus the diastolic velocity divided by the mean of all the velocities. And this is truly representative of the waveform. And therefore, I find that that is a better way to go about it. And therefore, we no longer use any of the indices except the pulsatility index. And the other figure that we do use is a peak systolic velocity, which we use to see in areas of high flow, such as in the middle cerebral artery in rhesus isoimmunization, which results in fetal anemia. So there we will use a peak systolic velocity, which is not an index. Otherwise, we've shifted to using the pulsatility index, and we almost do not use the other indices anymore. Now, the peak systolic velocity, whenever we have it, is one place where I always use mathematics, and we say that, look, the kind of flow I get is equal to an equation where we use a cosine of the angle alpha, which is the angle that the beam makes with the area that I'm insulating. So if that angle is too wide, then my peak systolic velocity will get altered accordingly. So this is one situation where we have to look at the angle and try and keep it as zero. And otherwise, we don't really have to worry about the Doppler equation. It doesn't really help in terms of explaining too much, because we used to need this when our machines were primitive. Now I press a button, I get flow for corpus callosum. I press a button, I get slow flow. I press a button, I get cardiac flow. I press another button, I get cardiac venous flow. So you don't need that understanding anymore. All you need is, yes, that I have a beam angle that I will make sure is correct and next to 0 when I'm measuring my peak systolic velocity. Otherwise, it's only pulsatility index where the angle truly does not matter. There is also 3D vascularization, but we don't use that so much in obstetrics. We actually use that more in gynecology, and so I will not discuss that today. So let's move on to our first clinical scenario, and that is fetal growth restriction. And we know that next to preterm birth, our biggest bulk of disease is fetal growth restriction, much more than preeclampsia. And then so the next thing we'll discuss is preeclampsia. And then we have this burden of Down syndrome. So we will go in this order. In preterm birth, we currently don't use Doppler for anything. But I will try and show you how we understand fetal growth restriction today, how we diagnose fetal growth restriction today and delivery decisions. And these are all based on our knowledge of Doppler. And let's see what we understand. That when we look to measure growth, we measure a parameter. We assign normality with software which tells us the charts. And you get to see then an estimation of fetal weight, which is again built in. And then you do color Doppler. Why color Doppler? For this reason. We need color Doppler because we're demonstrating flow in fetal vessels. And the vessels that are now being done increasingly and were not done so much earlier, we only did umbilical artery, we used to stop at that, and we don't do that anymore. We use the uterine artery and we reassess it at each growth scan, even if it was normal at the time of the 11 to 14 weeks window, and even if it is normal at the time of the 18 to 22 weeks window. We use it. And that is important. We calculate not just the middle cerebral artery in the umbilical artery and the umbilical artery pulsatility index, we get a ratio. The middle cerebral artery pulsatility index divided by the umbilical artery pulsatility index gives us the cerebral placental ratio and tells us about the redistribution of blood between placental flow and cranial flow. And that is far more reliable than using any of these by themselves. And then we have a newer one, which we now use increasingly, and that is the aortic isthmus. And it tells us how blood is stolen away from the fetal body through the carotid circulation, even though the ductus arteriosus brings it to the aorta. It goes backwards up the carotid circulation into the fetal brain, and the aortic isthmus will show those changes even before the ductus venosus is showing changes of hypoxia acidosis. And therefore, we use the aortic isthmus more and more, and it fits in somewhere before the ductus venosus goes haywire, and is very useful to do. Now, what do these vessels indicate? The uterine artery tells us about trophoblastic invasion, which happens in 2 waves, one before 12 weeks and one after 16 weeks, and then it keeps on going to 24 weeks, and it's quantified by the PI. The umbilical artery tells us about obliteration of the villi within the placenta, and that is measured by the PI. The middle cerebral artery tells you how more flow because of the fetal autonomic system being activated because of the aortic body chemoreceptors will throw more flow into the brain to protect the brain and of course the adrenals and the coronaries, and therefore we measure the middle cerebral artery to assess brain sparing. The aortic isthmus, like I said, will tell you also about the redistribution of cardiac output and will show changes before the venous side of the circulation, and the ductus venosus being on the right side of the heart circulation would reflect cardiac function and cardiac contractility, and therefore tells us about terminal events. And we use these, and for each one of these we use the pulsatility index. Now, this is the usual thing that you always hear, that yes, this is high impedance flow velocity waveform in the uterine artery, which often has a notch. This is normal at 11 to 14 weeks, and then after 22 or 24 weeks we always have plenty of flow and the notch disappears. And then we have umbilical artery, which I told you goes from ample flow at the end of the cycle to no flow to reverse flow. The middle cerebral artery, which first shows compensation, and then with edema it goes down. And the aortic isthmus, which initially is all on one side of the baseline, and then you find a little bit knock at the back from the valve, but still a lot of flow at the back, and then abundant flow in the reverse direction, which shows a lot of steal from the aortic circulation going up into the cranial circulation. Now, this is where we like to sample it, where the ductus arteriosus comes and meets it, and these are the waveforms, and it can also be done by a 3-vessel view. It doesn't matter which way we get it. Do remember that for all of these, we have a critical endpoint which is not one single figure. It's always gestational age-based, and therefore decisions are not based on a single cutoff. It's a cutoff for that particular vessel at that period of gestation, and that is extremely important. And because of this, we must understand that we don't have a cutoff which is a critical endpoint. It does not mean that you have a parameter that is abnormal. We will have to do an emergency cesarean to salvage the baby. No. It means that you truly have to see it in perspective and then decide how long to carry on, how safe it's going to be inside, how safe it's going to be outside. Also, very often decisions are made not on the basis of Doppler, but the maternal condition which might be deteriorating, and there Doppler plays a role to diagnose and to prognosticate, but not as a critical decision-making thing. There you have to then consider the maternal condition. Now, we've also divided growth restriction into less than 32 weeks and greater than 32 weeks because there's a difference. And a third one which is emerging, which we call the hypertensive growth restriction, which will get defined by next year. For today, we will discuss less than 32 weeks and greater than 32 weeks. And the important thing is that the ones that are earlier in onset are babies that are used to poverty. And they've adapted themselves. And the Doppler shows absolutely steady adaptation, which is sequential and predictable. Normal umbilical artery becoming abnormal, the middle cerebral artery showing compensation, the ductus venosus gradually showing poorer and poorer flow in the A wave, and then finally CTG changes and biophysical profile changes. The greater than 32 weeks is a fetus that's been living in luxury and might suddenly jump from absolutely normal umbilical artery, reasonably normal middle cerebral artery, to maybe some brain sparing, but suddenly intrauterine fetal demise because it's too much of a bulk and is just not adapted to poverty. And therefore they die. And therefore we have to be more careful about them. And then we need to know how best to handle it. Ductus venosus is the cornerstone for assessing when to deliver for early onset growth restriction, and cerebral placental ratio is a critical index for late onset growth restriction. And also the other differentiation we have to make is which is an SGA, which means just small, constitutionally small, or FGR. And now the ones that show that they are small but have Doppler signs of adaptation are the ones that are FGR. They have a higher risk of intrauterine demise, they need early delivery and poor perinatal outcome, whereas the SGAs don't really have this problem. And therefore there is a definition from the Barcelona group which says very clearly that, look, you take the weight, anything less than 10 centile is small for gestational age, and if it's less than 3rd centile, that is growth restriction. But even for the less than 10 centile, if the CPR is less than the 5th centile or the uterine artery is greater than the 95th centile, and you're still above the 3rd centile in weight, you will still treat that as a growth restriction and do a surveillance as growth restriction, not deliver, but a surveillance. The other group which defines this also says that, look, if a fetus falls not below the 10th centile, but has fallen 2 quartiles, 50 centiles, say from 80 to 30 or 70 to 20 is also growth restricted fetus and needs to be followed in the same way. Even if we use the Delphi consensus, which runs parallel with some people believe the Delphi consensus, some in the Barcelona group, they always include Doppler as part of defining growth restriction, not just weight alone. And that brings us to predicting 2 things. One, which are the babies that need to be followed? Is it SGA, is it FGR? Also, the ones that are still above the 10th centile but have fallen from a higher to a lower also need a follow-up. And the aim, of course, is to find out which is critical because we want to deliver as late as possible. We have a choice of a CCTG, computerized CTG biophysical profile and color Doppler. But what we really want to say is that, look, even with the CCTG, if it's okay, you're happy. But if it's not, you don't know how far you are from critical, and therefore you have to be very careful. And it's not a critical parameter for defining any of these things, because you could have a completely normal pH and yet be very close to dangerous pH. It's the same thing with the biophysical profile. By the time the movements disappear, and from the time that the fetal breathing movements disappeared earlier on, there's such a fall in the pH that we miss the critical pH of 7.1. And therefore it is not a critical parameter. We've been saying this for the last 27 years. This chart is from 27 years ago, that the CPR and the ductus venosus is what critically defines the critical pH of 7.1, and we really have to be careful about that. And the Barcelona people then go on to say that, look, once you've done this, you define several stages, 1, 2, 3, and 4, on the basis of umbilical artery MC and uterine artery PI. And then as conditions progress, you will decide when to deliver. So if there is end diastolic volume and a reverse in the aortic isthmus, you will still follow up. Reverse diastolic volume, what to do, and velocity, what to do, and ductus venosus and CT changes, what to do. And this is what they have given us. That look, in grade 1, in stage 1, where you have a weight less than 3rd centile, a CPR less than the 5th centile, and then of course a uterine artery PI greater than 95th, you need a weekly monitoring unless you reach 37 weeks, when you will induce. On the other hand, if you have absent end diastolic flow or a reversal in the aortic isthmus, you follow it up every 72 hours unless you reach 34 weeks, and then if your nursery is good enough, you deliver, and preferably by cesarean section, because the chances of fetal distress are very high. And so on for ductus venosus changes and so on. And typically this guides us now, and this is the best, when you don't even need to know too much of rocket science here. It's very, very simple. You just put it all onto a calculator, which is a free download, the gestational age, the Doppler parameters. We always enter the gender as male as a default because we don't do sex determinations. And it tells you, look, this is 37 weeks, deliver. With the same parameters, if I use the same calculator, and I go on to say, I'm 34 weeks, it says, look, the risk of outside is more than the risk of inside, therefore leave it alone and follow up in 1 week. It really makes life very simple, and particularly for the inexperienced, this is truly the best way of going about it. So basically, we've now divided this, and we're able to say this, and therefore, because it's part of the definition, we've now started doing scans at 36 weeks, almost in centers everywhere in the world that can afford this, and perhaps because we have such a high incidence of maternal poor nutritional habits, we might need to do this routinely at 30 weeks as well, because so many times the fundal height is much less than dates at this time, or they have a previous history of a fetus that was around 2.5 kilos and not really up to the mark. So these are the newer concepts that we must understand. Moving to the next parameter, which is very important, is fetal growth restriction, but that really kills mothers. And here we know that our Indian incidence of preeclampsia is much higher than the white population. Some populations in India with 27%. The average incidence of preeclampsia in the Western population, the Western white population, is 2.9%. The only real treatment is to deliver. And yet we know that if we discover it early enough, aspirin changes everything. An 82% drop in the rate of early preeclampsia and a 62% drop in the later preeclampsia. And we've always used clinical parameters, the NHS guidelines, the American College guidelines, but we realize it's not been enough. Because when we look at the detection rates, we realize that the NICE guidelines and the ACOG guidelines barely detect about 40%, and in the case of the ACOG, only 5%. Whereas if we do the addition of biochemistry, uterine artery Doppler and mean arterial pressure, we get 100% detection of the early preeclampsias and an 80% detection of the later preeclampsias, and therefore it's something that we must do. When should we do this? Well, the best window is 11 to 13 weeks because we need to give our aspirin early enough. We know it acts best before 16 weeks. And there has now been this wonderful aspirate trial and its follow-up trials. And therefore we realize that this method is truly the best, and we're getting the best results. So we use maternal characteristics, uterine artery Doppler, mean arterial pressure, PAPE, and the new PLGF, not so new anymore, which is a placental metabolite. And we say, okay, we will identify a risk factor, and those that are higher will then benefit from low-dose aspirin. Can we cut down on this or compromise? No. If you use only mean arterial pressure, or you were to use only uterine artery Doppler, and you were to exclude the biochemistry, or use a combination of these, you will never be as good as when you use all of them. So there are no shortcuts. You must use the PAPE, you must use the PLGFs. There's talk now of using only HCG and PLGF to cut costs. The tragedy is that with an incidence of between 8 and 27%, we cannot cut costs. The whole idea of preeclampsia is we've got to save those mothers. By the time this talk is through, 2 mothers somewhere in the world would have died of preeclampsia. And there's so many babies every year, that just get affected because of the effects of growth restriction as a consequence of preeclampsia that we cannot afford to compromise. And therefore, the correct way to do it is to have the entire thing and not use it piecemeal. Uterine artery Doppler by itself is very good, but it's much nicer to use it in perspective. And do remember that some of us do this vaginally, and therefore the cutoffs are different. Again, it's gestational age related, and this is always mentioned in the report. And although we do use a rough cutoff of 3.1 when we're doing a transvaginal approach, it's much nicer to use a gestational age related approach, put it into the entire formula of maternal characteristics and so on, and then give a risk and start the correct thing at the correct time. We've always talked a lot about what parameter to use. We take the right uterine artery, we take the left, and we take a mean. Not that the right is higher or the left is higher. No, that's not the way we approach it. Also, there was so much noise about the notch. We've been talking about the notch since ever, but a notch is perfectly natural in almost all the flow velocity waveforms we see at this stage, and therefore we've dropped the notch a long time ago. We use the PI, the mean PI of the right and the left, and we just drop the notch. We've had meta-analyses and all this data that I've mentioned here, which tells me clearly that I have to move beyond the notch, and of course that I must start my aspirin before the second wave of trophoblastic invasion by the syncytial trophoblast, and therefore I will get the best results. And then I will overcome all the effects of preeclampsia on my population. The low-dose aspirin, of course, as you know, has to be in a dose of 2.4 mg per kg, which translates to 150 mg, and not the standard 75. Standard 75 is okay for the infertility group, certainly not acceptable, because aspirin resistance is in as many as 30% of the risk population when you use only 75 milligrams, because the dose required for adjusting vascular proliferation, etc., is 150 mg, which translates to 2.4 mg per kg. The third common function that we've used is the detection of anemia in rhesus isoimmunized babies. And in this, what we do is we assess the ICT or the titer, antibody titer. That's not available very widely, so we go more by the ICT. And the moment you have a dilution of greater than 1 in 128, we say, okay, we must assess the fetal hemoglobin, but we don't do it by the Liley curves anymore. We don't do it with the amniocentesis. We do the peak systolic velocity within the middle cerebral artery, and we read it off from a chart in 1.5 MOM as a cutoff. It tells us that, yes, I need to do an invasive now, assess fetal hemoglobin, and then move on to give a transfusion at the same time. So we prepare for that at the same time. Moving on to the next section, which is the areas of utility. Very simple. I see a cystic mass. I want to know whether it's vascular or not. I switch on color. I get an answer. If I see a mass, I want to know whether it's vascular or avascular. I get an answer. So if I see vascularity in a mass that is bizarre, I start thinking of a fetal tumor. If I see it in a goiter which is active, I say, okay, I need to investigate this further, and this fetus might be having a thyroid abnormality in terms of function. I always use it for fetal cardiac evaluation, and as we will now discuss, also to assess the first trimester and for anatomical delineation, such as single umbilical artery, renal agenesis, to confirm omphalocele versus gastroschisis and so on, as we have discussed already. Now, here, for example, is the best example I find, that you're going through this brain, normal scan at 18 weeks, third trimester, face in the brain, cystic space. First thing you do is switch on color and you find turbulent flow. And you say, very likely vascular mass. And then we say, okay, let's do a 3D reconstruction, and you realize that, yes, this is your classical multiple feeders into the vein of Galen aneurysm, and of course, enlargement of the veins that drain it. And then you know that you can prognosticate accordingly, send them off to a pediatric neurosurgeon or a neurosurgeon for further evaluation during the antenatal phase, so that the parents are ready for this catastrophe. After all, it's not something that was present at the 18 to 20 week scan. In the neck, we tend to presume that, okay, all masses would be hygromas, angiomas. There could also be branchial cysts, and the branchial cysts will then show different displacements of the neck vessels, and so you can differentiate them and see whether the carotid is displaced medially or laterally. And here another one. I'm not sure, is this a good corpus callosum? Is it not? Is it dysgenesis? I find that in this is what I would have normally expected, my pericallosal artery looking so nice, but here the vessel just disappears, and therefore I know that this second half of the corpus callosum was not up to the mark. I look back and I say, yes, on 2D, even this part of the corpus callosum is not up to the mark, and therefore this is a dysgenesis of the corpus callosum. because the color gives me confidence to actually highlight this. Another example, the neck. I find a goiter, I find it is vascular. I know that yes, it is huge. Do I need to reduce this in size to enable a delivery? We do an amniocentesis, assess fetal thyroid function, and then we end up injecting L-toxin because we use the thyroid storm anyway. In Delhi it's available. You put it in there, the goiter goes down, and you can facilitate a vaginal delivery. Very simple procedure, but it needs knowledge, and it needs the availability of L-toxin and, of course, the will to be able to do a procedure. And, of course, all of this involves counseling, but that's not what we're discussing today. The fact is we're using a spectrum of Doppler to understand how to improve fetal outcomes. In the first trimester, when we do things, we, of course, look at nuchal translucency, CRL, and we put it into a clinical background. But we've also added ductus venosus and tricuspid regurgitation, because ductus venosus is an independent parameter compared to the nuchal translucency for the detection of trisomy 21. And whereas previously we used to use reverse flow, we now use reduced forward flow and a calculation of the PI to tell us which ones are in trouble, and that is the way we go about it. Remember that the ductus venosus is not only for trisomy 21, but for cardiac defects and the prediction of stillbirth as well, and therefore it gives us much more than just that. The same thing with tricuspid regurgitation, not as brilliant because it sort of goes with the nuchal translucency. And we have very strict parameters that we like to follow. The gate should be correct. You should have an apical 4-chamber view. And then we have this particular pattern, which is the normal pattern, the E wave, A wave, and a bit of reverse flow sometimes. But if that reversal is more than 60 centimeters per second, that is when you know you have to draw the line and be careful about assessing further for the tricuspid regurgitation. Do we do this on a regular basis? No. Primary screening is just using the nuchal translucency and the beta HCG and PAP-A, which gives us an 85 to 90% detection rate. If the patient is in private practice, we tend to add on the colors anyway, in which case our detection rate goes up to about 93 to 96%, but more importantly, our false positive rate, which means getting something that is positive where the fetus is normal, falls from the standard 5 to only 2.5%. So they truly reduce the false positivity in our combined first trimester combined test, and therefore it's very, very helpful. And therefore we routinely add them in private practice. This is what I mentioned earlier, that you have an association not only with the trisomy 21, but also with cardiac defects for the ductus venosus. We also use color routinely when we're doing in 11 to 14 weeks cardiac evaluation, both to show the ventricles as well as to show the outflows and to calculate the axis of the heart. And of course, ductus venosus and tricuspid regurgitation are additional pointers for aneuploidies, and therefore they can be used as well. And with newer equipment, we use radiant flow, which shines like this, like a 3D effect. And the sensitivity is so perfect. Look how beautifully we can mark out the vessels and we can mark out the actual ventricles in this 12-week fetus. This is 12 weeks in one day. So we're seeing everything in grayscale, but with a lot more confidence in the 4-chamber view when we see it with color. And you can as well predict in this that there is no ventricular septal defect at this stage. So the confidence goes up, the visualization goes up, and detection rate is excellent. Technology goes on and on and on. This is not something we do every day, but when you find a problem, then you can use these techniques. And in fact, a lot of Doppler evaluation of the heart is done on a routine basis, but that's beyond the basics. So I'm showing this slide because a lot of people involved with ultrasound, fetal medicine, and radiology have logged in, and they would find it useful to have a chart like this. But for the practicing obstetrician from a basic point of view, remember that we use colored Doppler now all the time as a problem-solving modality or to give us more information, and that's how it works out so beautifully well. We use it with 3D, such as a stick sequence, or we use it just as a standard 2D with my radiant flow, as you see here. Some of this Doppler stuff can be used in very advanced flows as well. For instance, the prediction of heart block in my lupus patients or my anti-Rho, anti-LA patients. And by that, we measure the mechanical PR interval and we know how to follow up these pregnancies and how frequently and when the pediatric cardiologist should be involved. We use them for handling arrhythmias, but that again, like I said, is not basic, it goes beyond. We also use them for the specialized assessment of twin pregnancies, and again, like I said, that is something that is way beyond the basic, but I like to mention these for the sake of completion. What I want to do is to give you two take-home messages. The first is that color Doppler is now an integral component of every obstetrical scan. Both routine and problem-solving protocols exist, as we have discussed, but do realize that technology is now extremely advanced and that Doppler is now practiced not only by radiologists and sonologists, but by people who have a grand experience and have a background in obstetrics, but are specialized in fetal medicine. And all of us work together. But what we really need is inputs, that we must have a clinical scenario that is in detail. A lot of us take our own histories, but sometimes the subtleties might be missed. So it's nice to send a detailed requisition saying, I have this problem, what do you do? Or just a phone call. Not a WhatsApp message, not a message because that can get delayed, not an SMS, but a phone call saying, how best can we handle this? And that dialogue is very important. We have to not live in these ivory towers, neither the radiologist, nor the fetal medicine specialist, nor the practicing obstetrician, but move on. And this is how we have to do. In an unrestricted budget situation, this is what we're practicing at the moment. At the 11 to 14 weeks, we add on color for ductus venosus, tricuspid regurgitation, fetal cardiac evaluation, umbilical cord morphology for a single umbilical artery, and uterine artery Doppler. In an ideal situation, not in an institutional situation, and not for population screening. At 18 to 22 weeks, the routine part is uterine artery Doppler, and the extended part is for anomalies detection and giving further information. In the third trimester, as you have learned, we've moved on. We don't use just the umbilical arteries screening. We know it's not sensitive enough. We know there are two groups, and we have umbilical artery, middle cerebral artery, the uterine artery, both right and left, the aortic isthmus and the ductus venosus, all to be done as part of a growth assessment, whether at 26, 28, 30, 36, 37 term, to get the right image. And with that, I thank you so much for your attention.
Thank you very much, Dr. Ashok Khurana, for a wonderful presentation on color Doppler, its uses in obstetrics. So you have not only spoken about the fetal growth restriction, preeclampsia, but you have also included the use of Doppler from early pregnancy, 11 to 14 week scan, as well as anatomy, study in TIFA, how to use uterine artery at that time, and color flow in umbilical artery as well as in MCA. So you have included everything and wonderful presentation, sir. I thank you on behalf of Dr. Alpesh Gandhi, myself, Dr. Sunil Shah, Joint Secretary Foxy, Team Foxy, and from all the viewers. Approximately 2,200 viewers are still there, and they have really enjoyed your presentation. Thank you very much, sir. And there are certain questions for you. I would take one by one. The one question is, in May 2019, FIGO has released new guidelines for preeclampsia. And according to this viewer, it says that it discourages the use of PAPE and recommend more use of placental growth factor with maternal characteristic. So what is your opinion, sir? And what about FIGO guidelines?
Yeah, this is not a true interpretation of the FIGO guidelines. The fact is that if you were to do one parameter to figure out one disease which has a higher incidence than Down syndrome, then that is fine. You go ahead and do the PLGF. But remember that a low PAPE is also an indicator not only for Down syndrome, but also for a generally poor prognosis of placental function in the rest of pregnancy. And therefore, it is necessary. If you're not doing a PAPE, you're not doing an adequate evaluation for Down syndrome. So it's like saying, I will only do for the important part of the disease. I will not do for the other part of the disease. What Figo certainly said was that, look, in countries which have resource restriction, please do a mean arterial pressure and the rest of it without uterine artery Doppler and without biochemistry. It did not say do only PLGF. Yes, statistically, you can get the same answer without a PAPE. The PAPE doesn't change it much. But the PAPE is basic to my understanding of Down syndrome, which is why that scan was done in the first place. And either I do NIPT or I do PAPE. Now, obviously, NIPT is going to be so expensive, it's not going to make any sense. So the one that I will always do will be a PAPE. So it's a misinterpretation of what they've actually said. They actually very clearly said that if you had to choose and only screen for preeclampsia, yes. But we have to have a whole picture. And since I don't have that much money to do an NIPT, I'll have to do PAPE for my Down syndrome.
Okay,
So
thank you very much, sir, for very nicely explaining about why PAPE and not a placental growth factor or NIPT. In another question, in suspected intrauterine fetal distress, whether we should ask for aortic isthmus Doppler or ductus venosus, and ductus venosus study, and up to what time obstetrician can wait after umbilical artery diastolic blood flow is either absent or reversal has started, and still we can wait for 1 or 2 days more, or we should wait for the ductus venosus changes to happen.
Yes, so in that situation, we again go back to our Barcelona protocol, which I discussed, and which clearly says that, look, if it's this many weeks and your nursery is good, that is what we should follow. Because even with absent flow, we have carried on pregnancies with a normal neurological outcome for as many as 7 to 9 weeks, which means we managed to take pregnancies from 27 weeks to 34 weeks. And therefore, we are very, very happy not to use them as a critical endpoint. And this was the slide I showed earlier. And if I may share my screen once again, then we do realize that, yes, this was the situation then, that it's very, very straightforward, that I am told exactly what to do. There is absent flow, umbilical artery, absent diastolic velocity. I will look at my aortic isthmus. If there is reversal of flow, I will still do twice a week if I'm less than 34 weeks. And in this situation, I would then use my ductus venosus to follow up, because that's what I like to do up to 32 weeks of pregnancy. So that is the way we actually follow these. And therefore, our life has been made quite simple thanks to the availability of this kind of a situation. That, look, I have these guidelines, I have a calculator, I just put it in there and I use it, or I have this chart and I just use it. So I don't use absent end diastolic flow as a guideline. Of course, if I were to see it for the first time at 38 weeks, I know I have to deliver. But if I see it as early as, say, 27, you wait, you watch, you see the whole picture, you monitor the patient, repeat the scan, do multi-vessel Doppler each time, follow the Barcelona protocol, and you will do very well.
Very good, sir. So you wanted to say, but this question or query is from my side.
Yeah.
Am I audible? Now suppose there is absent diastolic flow as well as reversal of umbilical artery diastolic flow. MCA is less. There is a severe oligohydramnios. And then also we need to wait for some time, or will it cause a more fetal hypoxia and acidosis? Then baby is in a better environment in an incubator than in an in utero environment.
Exactly. So in this situation, then I go on to see what my ductus venosus shows, and then also to see whether I'm more than 26 weeks. Is my nursery adequate? Is it not adequate? Is my neonatology adequate? Have I been given steroids for lung maturity or not? And then you take a decision, because the more critical you get, and the worse the CPR gets altered beyond 32 weeks, and the worse the ductus venosus becomes before 32 weeks, you know you're nearing the end. And that is important.
Thank you, sir. And now there is a question, because many of the viewers are coming not from the metro cities, but they come from the smaller cities and where the facility is less. And some of the obstetrician wants to buy a Doppler. So would you recommend up to which level of a Doppler machine they can buy?
Yes. So you see, currently, the cost of a Doppler unit and the cost of a black and white unit is pretty similar when you want some sort of resolution for obstetrics. You can't use a low level, entry level machine for obstetrics, except perhaps to reconfirm for myself, is it breachocephalic? Is it, how much of it is placenta previa? Is there a heartbeat? Is there no heartbeat? Now, that sort of practice, you can just use a simple point of care unit. Beyond that, when you choose, to add Doppler to an ultrasound unit today is not expensive. And in fact, you have black and white units, grayscale units that are much more expensive than Doppler units. So you must use a machine that is a medium end machine that would allow you to do most of your obstetric work. And if you have somebody coming from outside, like a radiologist, a neurologist, or a fetal medicine expert, then you need to offer them a good machine. And the Doppler should be there. So a medium end machine, the kind that we say would be costed somewhere between 12 and 24 lakhs in India today, as a rough estimate. You get much cheaper ones. You get second-hand units. You get units that are refurbished units, which are much less expensive. So depending on your own practice, and do remember that when you're in a place that is not a metro town, you have to take decisions on the spot. The patient cannot be transported. Our methods of transport are getting worse. There's too much traffic on the road, and in utero transfer may not be possible. So you truly need more technology in the areas that are more remote. So if I was in a very remote area, I would actually use a higher end unit. And if I'm in the metro, I know that I have the possibility of further referral, so I would use a less expensive unit. So it works the reverse, not this way.
Okay, sir. Now another question for a middle population cities and the town. Give us a good idea of uterine artery pulsatility index at 11 to 14 weeks pregnancy to diagnose IUGR preeclampsia, or the prediction of IUGR and preeclampsia at 11 to 14 weeks. Uterine artery PI at 20 weeks. As you said that now pre-diastolic notch is no more in use, right?
Right.
So tell us, because we normally don't have that chart, but can you give us some idea if this pulsatility index in uterine artery at 11 to 14 weeks, at 20 weeks can end, right? These two things, this is my question for the general public.
Yeah. So at 11 to 14 weeks, if I'm doing a transvaginal scan, I can use a mean PI of 3.1 as a cutoff. But if I'm doing a transabdominal scan, which is what I do most of the time for my 11 to 14 weeks, I have to have an age-related gestational age-related cutoff, because my 11-week 5-day cutoff is much different from my 13 weeks 2-day cutoff. So I have to have that. And these days, every single ultrasound machine can be programmed, and you can show a graph automatically. I would always use that. It's exactly the same on whether I'm looking at 18 weeks or 20 weeks or 22 weeks. I would never use this cutoff. We used this cutoff for the nuchal translucency many years ago as 3 millimeters. We made our mistakes. We know that we must go by 3 millimeters for significantly larger numbers, but there are a lot of Down syndrome sitting there with a nuchal of 2.7 at say 12 weeks and 2 days. So I always insist that, look, if technology is involved and statistics have evolved, we must use the latest, and we have to use gestation age related charts. No compromise.
Fantastic, sir. Very nice answer. I am very happy, because if you take a 3 millimeter cutoff, you have missed many Down syndrome. Similarly, PI at 11 weeks is different and 13 weeks is different. And another very good answer, your sonography machine should be very good at whatever place you are working. Maybe it should not be lower level, and color Doppler is the tool for a successful obstetric outcome. Thank you very much, sir. And most of the questions I have taken, and I hope people are appreciating. There are lots of appreciating you and your presentation about the question answer session. So I, Dr. Sunil Shah, thanks again on behalf of the Foxy. Thank you very much. Thank you very much, Corona people, for this webinar. And thanks a lot, Dr. Alpesh Gandhi and Dr. Jaideep Tank. Thank you.
Thank you very much.